going to go ahead and get started. So my name is Dr. Kristin Castorino, and I'm a senior research physician here at Sansum Diabetes Research Institute in Santa Barbara, California. Thank you all for joining and attending today for this very timely and important topic. A huge thank you to our panelists for all taking time out of your very busy day in the midst of this pandemic to help arm parents with information so that each person can make the individual decision that's best for them. I am truly awestruck by all of these incredible women that are here with us today who are experts in all their various fields and areas. So today what we're going to do is we're first going to get into some introductions, and then we'll go through about 45 minutes of question and answer. Thank you all for submitting your questions ahead of time. That really helps us organize the information so that we get as much jam-packed in this hour as possible. And then we'll hopefully have a few minutes at the end to address any questions that didn't get answered during this town hall. If you do have a question during this webinar, you can enter it in the Q&A area at the bottom of your screen for this web, and we will review it, and if we can, we'll try and get to it. Again, this webinar will be an hour long, and we'll try and cover as much as we can. So as you all know, there is a tremendous need for this town hall to try and figure out the game plan for each child in our lives. And what makes it harder is that what the reality is changes day by day and by region. So it's important that you make the decision that's right for your family that also is with the input of your healthcare provider and your diabetes care team. The information you hear today is not medical advice and serves to inform and empower families as you make very individual decisions of how to approach this school year in your community. And at the end of the presentation, we'll have links up for the very helpful resources for you and your family. So the revolving slides that you saw at the beginning, we'll have that at the end. So don't worry if you didn't get them or didn't screenshot them, we'll have them later. So now I'll move forward and introduce the panelist speakers and have them each share a little bit about their background and why taking care of these kids with diabetes is so very important to them. So I'm going to start off with Dr. Kaufman, or Fran, as we all call her.
Oh, I'm supposed to say a little bit about myself.
Fran, can you share with everybody a little bit about, you know, if I read everybody's bios today, we would be here for a couple hours. So I want to just jump in. If you could tell us a little bit about why this is so important to you.
Sure. Well, I'm a pediatric endocrinologist, and I've been doing pediatric endocrine for about 40 years. And I'm very concerned about this issue for my patients. I'm also a grandmother, which, may I suggest to everyone, is the best role in life. And if you can just skip parenting and go straight to grandparenting, think about it. You know, obviously, we want to keep our children safe, we want to keep our teachers safe, and we want to be able to really combat this pandemic.
Great, thank you. And Dr. Singleton, could you tell us a little bit about yourself and how this impacts you?
Hi, good afternoon, everyone. My name is Dr. Kristin Smith. I am a pediatrician and preventive medicine physician by training here in Atlanta, Georgia. This is important to me for several reasons. The first and foremost is that as a pediatrician, by training, and as a parent, I am very concerned that we as a community do all that we can to protect our communities and our children and our families during this very challenging time. I also am the child of 2 teachers, and so I am very sensitive to the challenges that teachers are experiencing during this important time. But most importantly, I'm a community physician, and I want to help our community be safer.
Thank you very much. And moving on to Crystal Woodward.
Good evening, everyone. Thanks for being here. I'm Crystal Woodward. I'm the director of the American Diabetes Association's Safe at School campaign, based in our home office out of Arlington, Virginia. I am also a T1D parent. I have a 30-year-old daughter who was diagnosed with T1D at the tender age of 17 months. I care about this issue, and I'm here tonight to make sure you as parents, teachers, caregivers have the tools and resources you need to return our kids to school, or whether they're going to be distance learning, in-person learning, or a hybrid learning. I want to make sure that you understand your children have legal protections, even during a global pandemic. So we're here to, my role in this panel tonight is to talk a little bit about those legal protections and what those look like in the COVID-19 era.
Thank you. And moving on to Joyce.
Hi, good evening. I'm Joyce Beaudoin. I reside in Apopka, Florida, outside of Orlando, Florida, the 9th largest school district in the country. I'm here as a parent of a child with type 1 diabetes. She was diagnosed at the age of 4. She will be 17 tomorrow. So I'm here representing the parents. I'm also a volunteer and a trained Safe at School advocate with the American Diabetes Association, where I have facilitated many workshops and worked with many parents over the years to help bridge that gap between the school and the parent, and helping parents overcome some of that overwhelming anxiety, especially with newly diagnosed parents. So I'm here to add my input and suggestions to really, as a parent, share some insights as well.
Thank you so much. And Leah.
Well, thank you, Kristin. It's so nice to be on the panel. I'm a pediatric diabetes nurse educator. I'm also the team lead for the Diabetes Resource Nurse Program in Colorado, which supports school nurses, and I'm a retired school nurse. So this is a very important topic, as everyone has said, and I really want to help parents have the knowledge so that they can keep their child healthy, safe, and ready to learn.
Thank you so much, everybody. And we'll jump in for our first question. So the first question is for Fran or Dr. Kaufman. Is it safe for students and T1D teachers to return to school in person?
Well, if I knew the answer to that, I might get a Nobel Prize. And if there was an answer to that, none of us would need to be here. This is a very dynamic time. I am in Los Angeles. We are now facing our second lockdown. Our schools have now been closed for in-presence learning, at least to an undetermined amount of time. And I think the hardest thing for everybody, and maybe why you're all here, is in the end, this is going to be somewhat an individual decision between you, your spouse, your child, if they can assent or consent, and maybe your healthcare provider, hopefully, your diabetes specialist, and any other resource that you might have who can help with this decision making. But there is no doubt that before we can send people back to the school itself, we have to be sure that all of the measures are in place. I know a number of us have been working with different school districts, different schools, to be able to have all the things, the masks, the distancing, the cleaning, the air filtration, the ability to check for somebody as they're coming in, leaving parents back out of the school as much as possible. A whole host of things that have been written about by educators, by endocrinologists, by public health people, and certainly by the American Academy of Pediatrics. And let me just say a little bit about that group. They have come out with a position statement which makes sense, maybe not right this minute, but certainly what we are all striving for, which is to get our kids back into the classroom as safe as possible for all of them, as well as the teachers, all the other adults who interface with those children in the school environment. And they really have been promoting whatever it might take to be able to get to that point as soon as possible. And their position statement is very thoughtful and for some a little bit provocative. So I'm a member of the Los Angeles chapter of the American Academy School Support Group. And we've had a very, very active number of pediatricians weighing in on whether they think it's safe right now, what all the measures need to be. And I will tell you, there's quite a diversity of opinion amongst pediatricians, as you can imagine. So there, many of the school districts will be delayed in getting kids back in the classroom. Some may be starting right at the beginning of the year. I think as individual parents, you'll need to see what is the school providing, what are the physical measures they are taking to keep our children as safe as possible. And then also, I think the unique aspect of a parent of a child with type 1, particularly for those in the lower elementary school grades, is what's the ability to help that child with their diabetes while they are in school. So there should be a long list of things you want to find out about. I think we'll help develop that list for you. You can get that list in a number of places. You can see the statement of the American Academy of Pediatrics and see the measures that they think are important. Find out how your school is going to comply, how your school is going to help your child with their type 1 diabetes and its management, and really make a very difficult and very thoughtful decision when the time comes. Hopefully, it will appear and be in reality as safe as is possible to get our kids back to school. But there's no one answer, and the difficulty for all of you will be, this will be a very individual decision. It can obviously be changed over time. You can put your children back in school. You may have to take them back out of school. The school may have to shut down, because this is a very, very dynamic time. One day, the next day, and we don't know what the days in the future are really going to hold.
Thank you so much. And to some of your points, I want to ask, this is for Dr. Singleton. Can you review the recommended guidance for social distancing and spacing in schools?
Thank you. At the current time, the Centers for Disease Control, we recommend a three-pronged approach for preventing the spread of COVID-19 in localities. The first is what we call social distancing, of keeping people 6 feet apart. So for a school setting, what we hope is that the school set will be able to space the children in seating arrangements, movement arrangements, so that they remain 6 feet apart. So the desks are 6 feet apart, or the way they move in the hallways. That's one leg of that three-legged stool. The second level of that three-legged stool is hand hygiene. And so again, hand washing, keeping surfaces clean. And then the third is the use of face coverings, so that people over age 2 who can tolerate the use of some sort of cloth face covering was what we would recommend. And so in a school setting, if your school is offering in-person learning, and if that is an option for your school, that's one of the questions that we would suggest that you ensure that those accommodations can be provided.
Thank you. So it sounds straightforward, but it's really in the implementation.
Correct.
Okay. And moving on, oh, was someone gonna say something? And I just want to let all of our participants know that Dr. Singleton is where she's at. There's a storm passing through, so if you see her freezing, that's okay. We know it. It is probably her waxing and waning internet connection. So moving on to, this question is for Crystal. Do the legal rights and protections for students with diabetes change during a pandemic?
No, the rights of students with diabetes do not change. They do not go away during a global pandemic. Whether it's in-person learning, distance learning, or the hybrid model, accommodations should stay in place for the student. And these can include having the ability to take an exam at an alternate time if blood glucose levels are out of range. They include self-management anywhere, anytime for capable students. They include the ability to have extra absences or tardies for illness or medical appointments. And also they include the ability of these students to have full participation in all extracurricular school-sponsored activities. And I'm talking about the varsity football team, cheerleading, drama club, science club. Just because the child has diabetes during a global pandemic doesn't mean the child should be denied this opportunity to fully participate. And taking this one step further, not only should the child be allowed to fully participate, but there should be a trained coach, teacher, mentor, someone else on the premises who is available to respond to that child's needs. With all this said, I really encourage parents, schools, school nurses, teachers, school staff, everyone to be open-minded. We have to be open-minded. There's so many unknowns. When we're returning to school, no matter which model you choose for your child, we're all returning to a new normal. So we need to be reasonable in our expectations.
Great. And what about for students who, or families who choose to attend a private school?
Well, that for families who choose to attend private school, a lot of their rights are based on whether the private school is religious, whether the private school receives federal funding. So for both religious and private schools receiving federal funding, those schools do have obligations to provide services to children with diabetes under Section 504 and or the Americans with Disabilities Act. There's a lot of good information on the association's website if folks want to take a deep dive and read about how those laws are applicable to students with diabetes.
Thank you. And moving on to Joyce, as a parent of a child with diabetes, what are your key concerns about returning to school when it is time to return to school?
And you kind of hit the nail on the head there. Thank you, Kristin. It is if and when, right? Because it varies so much by state and even within the state, school districts within the state. But to piggyback on what Crystal said, there's so many unknowns. So one of my concerns as a parent and some of the other parents that I've spoken with are with so many unknowns and so many things to figure out in some districts a very short period of time. I'm concerned about will the planning for diabetes management and care for children with diabetes get lost in the shuffle, if you will, with so many things to plan for and to think about. And in general, specific to the diabetes, I'm concerned about the protocols that will be put in place. Some schools have nurses, some have health clinic aides, or others that provide the care. And some of us have built good relationships with those providers or those caregivers over the years. So the turnover concerns me. It concerns me as to with additional protocols to be put in place for those healthcare professionals within the school system as it relates to COVID, that the other protocols that also need to be in place for children with diabetes have to all now be managed, which I'm sure can be overwhelming for those providers as well. I'm concerned about as policies are being written for distance learning, for example, how are they incorporating the children with diabetes and those with existing 504s or IEPs into that planning as well. I'm also concerned about the varying options that are offered and how much information we may have as it relates to diabetes care up front to make a well informed decision as well. And finally, I'm concerned generally about the ratios overall, just in terms of the number of students, how they may be treated, if you will. I know here in Orange County, I've seen some options where there's been discussions about putting all the students with the 504 in the same classroom. I'm sure there's varying opinions and pros and cons to that. But again, none of that, all of it's fluid. So I'm concerned about making decisions without having all the information as it relates to our children with diabetes as well.
Oh man, it is tough upon tough.
Mm-hmm.
This question is to Leah. What training is being provided to school staff on sanitizing school facilities, wearing PPE, sending students to the restroom, serving lunch, playground activities? You know, for example, I saw one of the participants ask when, you know, my kid, in general, they're wearing a mask if they're less than 6 feet, but outside of the 6 feet, they're taking their mask off. So what are schools doing?
Leah, you're muted.
Well,
There you go.
this is going to vary depending on what school or school district you're in. So I want to give some key points of what to ask and what to look for. So as all of those that you mentioned are important trainings, but measures that really need to happen regarding training is that the training should occur for school staff before school starts so that they know what they need to know to provide safety when school starts. They need to have a practice run of these processes. Like you mentioned, when they're going to the restroom, what's the process? What if they have someone that's sick that has symptoms? What is the process? So they need to have a practice drill, and this should include care of the student with chronic health conditions such as diabetes. Routine care, that should be a part of that practice school day so that it becomes, so the staff works out any bugs that may be in the process and they're comfortable with it. They understand it. And they need to make sure they have the equipment they need, the personal protective equipment they have. Do they have communication plans so that who do they contact when they think they have someone that may have COVID? Those type of plans in place. Now, as far as training, some of the important training components should be about using personal protective equipment. For most people, this is going to be those face coverings. So they need to talk about it, like you said, in the classroom versus when they're on the playground or at recess. Hand hygiene, respiratory etiquette. Those things need to be covered with the staff and, of course, with students as well. The processes for who is my contact for COVID-19. This may be the school nurse, and if they suspect that someone has symptoms of COVID-19, what is the process? Where do they go? Those are some of the key concerns that need to be covered in the training before school starts.
Perfect. And this is one of the most common questions and potentially misconceptions that I see is a person or students or child with diabetes, and this question is to Dr. Kaufman, child with diabetes at higher risk for getting COVID-19?
So that is a question everybody wants to know, I'm sure, on this panel. And there is not any evidence to suggest that your children with type 1, particularly at a young age, hopefully well controlled with glucose monitoring and appropriate insulin dosing, that they are immune compromised in any way. They are not. We do not think they're going to get the infection more frequently or at a higher risk to get the infection. However, when they do, there is concern about a number of things. One is that the glucose can elevate as a result of any illness. I would assume most of you have had a child who's gotten a cold and the glucose value sometimes gets high, hard to treat. Well, with COVID, it may be even higher. There's some evidence of looking at new onset diabetes patients in Germany. They just came out with a very interesting report. And most of them just at new onset were having more hyperglycemia, more diabetic ketoacidosis. Part of it, maybe they didn't get to a healthcare provider in time. You know, everybody's focused on COVID and not on diabetes. So I really, really implore you that if your child does get sick, and some of these children, when they go back to school, are going to get sick with just a common other illness, a sore throat, a strep infection, something else, that glucose monitoring is incredibly important, assuring that the child doesn't end up in ketoacidosis. The child is hydrated. You should have a very effective 6-day plan, articulated all the things you need, the ketone monitoring, the glucose monitoring, the extra insulin, the electrolyte solutions, all those things on hand. And I think there's a question, I'll talk about it even more. So when, you know, we don't think they're more susceptible, but if they do get the infection, we're concerned about their diabetes management and their risk of entering diabetic ketoacidosis and having some period of sustained hyperglycemia. Now, what we've read in the literature, you know, the word diabetes is thrown around all the time. Diabetes has a much higher mortality rate. Diabetes has a much higher incidence of being in the intensive care unit. Those reports, particularly the ones early on from China, and even the ones from Europe, were in adults. They were in adults who most likely had type 2 diabetes and all of that associated comorbidity of obesity, dyslipidemia, heart disease, maybe renal disease, and those comorbidities, along with the fact that now their glucose values were very hard to manage as well, put them at greater risk, higher risk for needing an ICU bed, and even higher risk for mortality. But that's very distinct from what your children are at risk from. They are not more susceptible. We don't think they're likely going to get sicker from COVID itself, but get sick if their diabetes is not appropriately managed. So I think if you when we send the children back to school, and likely there will still be some COVID, I don't think you have to worry that they're going to get more infected. I think you have to worry that if they do, that you have to be very diligent in managing their diabetes. And obviously, if you can't manage it, get care as help as soon as possible, which may require an IV insulin, obviously an ED visit, or even a hospitalization.
Thank you. And Dr. Singleton, how would you approach this question of whether children with type 1 or type 2 are at higher risk for contracting COVID-19?
Yes, thank you for that question. I would agree with Dr. Kaufman. At this time, we don't know if all children with underlying medical conditions are at higher risk for severe illness. What we have seen is that those children who needed to have hospitalization for COVID-19 had at least one underlying medical condition. And the most common conditions among children included chronic lung disease, heart disease, and again, conditions that weaken the immune system. So we have seen it in that group of children. One of the things that we have learned about this virus is the way that it attacks and does its damage is that it goes after the immune system. And so if you have a situation where your immune components are out of whack, so in the adults, those with cancer, those with severe chronic lung disease. And again, as Dr. Kaufman mentioned, those with type 2 diabetics have been the ones that have been shown to have more severe illness. Type 1 diabetics, it's not to say that we have seen COVID in that, but again, more so in the adult population. But one of the things that we have also learned with children is that children sometimes present with different symptoms, if at all. And the symptoms sometimes that they present with are things where they have had stomach pains or kind of GI upset. So for a child with type 1 diabetes who has not maybe stayed in control, and sometimes a case may be presenting more with DKA, that's pieces connected together. So one thing that we have noticed is that it's so important that you and your child are on track to stay compliant with your routine, and to advocate for your child to be able to stay on their routine, and to make sure that your child, particularly our teenagers with type 1, that they are eating according to plan and moving according to plan. One encouraging study we just saw recently was showing that in Italy, so the kids with type 1 diabetes that in those early days that went home when they were not quite lockdowns, but were starting to restrict activities and may not have been as active. Then when they went home, because people were focused more on what they were eating and how they were moving, that they actually stayed in better control. So the bottom line is, how can we keep them as close to their routine as possible, which keeps them at lower risk for severe illness. And as we learn more about children, we will be able to update our guidance accordingly. But for right now, children with type 1, they might have concerns, but they are not at definitively higher risk like we have seen with our type 2 diabetics.
If I could just add one thing, we are trying to gather this data. There's a couple efforts going on now to, on the pediatric endocrinologist side, to record any patient with type 1 or type 2 who's in the pediatric age range who gets COVID, to really categorize what happens during that illness. So we're learning all the time, as Christa suggests. It's a lot of new data coming out all the time. Matter of fact, you can barely pick up a medical journal in which, if not all of it, at least most of it is about COVID, about new data that's coming out, about new ways to look at data. It's a little hard to do all the real rigorous randomized trials we are used to doing in medicine. We're really doing experiential kind of research. But we are really trying to get to a knowledge base that will continue to inform us. And we made great strides with those who do end up in an ICU, obviously, again, mainly adults, but children as well. We've learned a lot about the management, some of the medications that are efficacious, and we're going to keep learning. And one of those focus groups is around the children with diabetes.
Yes, the one last point is that one of the things that we at CDC have been advocating for, and as we update our guidance as it pertains to school, is making sure that children have access to whatever learning environment, that if they miss school for any reason, that they are able to make up any work without penalty, so that again, that their learning will continue. If it does not happen in the classroom, so be it, that they are, so we don't add to the stress of them in this stressful time period. So again, our goal is to keep them on their routines, keep them in their stable state, so that whatever their management plan is, that we don't deviate from that, so that they won't hopefully get into more trouble with their diabetes control.
Thank you. And one quick clarification to Fran. The immunocompromised, is someone with type 1 diabetes or well-controlled diabetes immunocompromised or not, or does it matter whether they're well-controlled or not well-controlled? Could you provide more information about your opinion or your expert opinion on whether someone is immunocompromised or not?
I would say through the 40 years I've been a pediatric endocrinologist taking care of thousands of children with diabetes, what I've heard more often from the parents is, my child with diabetes never gets sick. My other kids get all the colds and the streps and everything else. So there's no evidence that a child with type 1 diabetes or type 2 diabetes has immune compromise, so that they're not missing some of the cells that help fight infection. They're not really missing the factors that enable us to perform an immune response. Over years, decades, in somebody with long-standing, poorly controlled diabetes, there's some change in some of the tissues, there's some change in some of the blood factors that may make them quasi-immune compromised, but we don't see that in the children. So they should not be more susceptible to getting the infection. I do want to add one thing that maybe the children with type 2, the adolescents, most type 2 diabetes in the pediatric age ranges in adolescents or young adults, they may be a little bit more at risk because they've already got some of those comorbidities, obesity, dyslipidemia. We have evidence that some of them already have some cardiac changes already in their vasculature. So, and often they're not maybe on insulin, and so, and perhaps not as, and part of this is due to the medical system itself feeling that type 2 is less diabetes than type 1. In the adolescent, it's not. It's a very, very serious condition. So we need to be particularly careful about our children with type 2 diabetes.
Thank you. And we're going to shift gears a little bit and talk about 504 plan. So this question goes to Crystal. One participant in the pre-submitted questions asked, my child's school nurse and teachers are wonderful. Everything's going great. Do I still need a 504? And if so, how do I get one? Where do I even, what is it? Where do I get one?
Well, our recommendation is it's better to be proactive rather than reactive. And now is the time to put a 504 plan in place, especially if everything is going well at school. Let's get it in writing. The process for that is the parent can reach out to the 504 coordinator at your child's school. That might be a school principal, it might be a guidance counselor, it might be a teacher, it might be someone else. But reach out to that 504 coordinator to get the process started. And normally what that process will entail is a group, the team, the 504 IEP team will come together. The team should consist of people who are knowledgeable about your child. They will come together and decide if diabetes is a physical or mental impairment that substantially limits a major life activity. And I know that's a mouthful, but just know that diabetes is a disability under the Americans with Disabilities Act in Section 504. It's a legal term of art. It's not a label. That word disability will enable parents to secure accommodations for their child. It's always advisable, always, to put accommodations in place. I always say if it's not in writing, it was never said. If it's not in writing, it never happened. So very important to put everything in writing. Also, and it's not just about the plan. The 504 plan entails a process. It's a process for the school team and the parents to come together to determine which accommodations are needed by the individual students. So it's individualized. It's also a process by which, if there's a problem somewhere down the line, the team can be reconvened to tweak the plan, to identify the source of the problem, and to fix the problem. But just understand that it is very important to have that 504 plan, and it's very important also for everybody to know their roles, to know what the expectations are. What's the teacher's role? What's the school nurse's role? What's the student's role? So absolutely, positively, we recommend a 504 plan.
Great. Anybody else want to add in on the 504 plan? Sounds like every child with diabetes should have one.
Yes.
Yes, they should have a 504, an IEP, or some type of written accommodations plan, even if we don't call it a 504. The accommodations should be in writing. That's what's important.
Thank you. And Joyce, what is the best approach for a parent in negotiating the accommodation they want, or what they want to include in the 504 plan, especially when when they're getting some pushback or objection?
Okay, very good question. The first thing is to be prepared, right? To really think through what you are requesting, and really, I recommend writing it down as well, so that you can really be planful and thoughtful in terms of what are your non-negotiables as it relates to the child, and then what are some of those things that you're willing to negotiate in terms of including in the 504 plan. I will say, both as a parent and as an advocate for parent, I know sitting in those meetings, sometimes the emotions can come up when the school does not necessarily agree with something in terms of an accommodation. So sometimes it's great to have someone with you that can just really help you think through or talk through it in advance. When the school does object, what I've found over the years, and with parents and with my own experience, is most of the time it's because they don't understand type 1 diabetes. So take the time to educate on type 1 diabetes and why you're asking for that particular accommodation. Provide the school with resources. Give them, go to the various websites, JDRF, ADA, and provide the school with resources that can help educate them on those things, but be reasonable as well. I heard Crystal say earlier to be patient and to be reasonable as well, to understand that most of the time when the school is not agreeable to a certain accommodation, it's because they don't quite understand why it may be very important, but be willing to negotiate alternatives and be able to think through what some of those alternatives are for. And most importantly, remember what the objective is. It's to keep your kids safe, to keep our kids safe in school. And there are many times multiple ways to accomplish that. And so again, be willing to negotiate on those items that are where there are several ways to make sure that the child is safe. It might not be your preference, but also understand where the school is coming from. And I know when we're sitting in those meetings, it feels like it is all about our child. I'm a parent, it is all about my child, and I'm in those meetings, but the school is responsible for all of the children, keeping all of the children safe, all of the children with and without a 504. So again, be reasonable and approach it with a spirit of cooperation. Again, so be planful and thoughtful. Write out some of your requests and follow up with educational resources. Rely on your CDE, your diabetes educators, your endocrinologists to help you formulate some of the why behind why some of those accommodations are being requested.
Thank you. And moving on to Leah, I wanted to, so it sounds like for many schools in the United States, we will be doing distance learning in some way, shape, or form. So many of us will not be going into the classroom, in a couple weeks. What medical services, how do those translate to being at home? Oh, and you're muted. Unmute real quick.
Thank you for reminding me. Thank you for this question. The school nurse can offer many services to the child that will be doing remote learning. One of the most important ones is connecting them to community resources. Do they have a need for access to diabetes supplies, including insulin? School supplies? Is there food insecurities? All of these type of community resources the school nurse can help connect the child and family with. Additionally, the school nurse can help with care coordination, assisting the family with meeting with the child's endocrinologist and getting updated school orders the diabetes medical management plan. All of these can be very helpful. Additionally, the school nurse can help the child with trying to increase or stay in their blood sugar stay in range. That time in range is very important, and the goal is 70% can still be achieved at home, and the school nurse can help with this. Also assisting when there's hypo or hyperglycemia questions, or if they're seeing trends and that sort of thing. Finally, helping with the Section 504 plan, like Christa was talking about. They are a good resource for the parent and what accommodations are needed, particularly during this time of COVID. They're, making sure that the student has the accommodation that they are not getting their routine diabetes care with sick children. They should be in a well health room, for an example. But many services the school nurse can offer to the child and family.
Thank you. And switching gears, this question is to Fran. So in the event that a child with diabetes does develop COVID-19, or what should they do? What do you recommend?
Well, obviously, if that occurs, you need to assess your child's health status. So this is where I think having a flow sheet and becoming a quick medical professional is a route to go, because data is what your physician or healthcare team is going to want to see. So what's the temperature? What are the symptoms? And then, of course, go into that sick day management mode around a sick day and what it can do to glucose values and ketones. So in preparation, you should have a way to measure ketones, preferably blood, but if you can't get that, for sure, urine. Be sure those strips are in date and operational. Obviously, some kind of glucose monitoring. If you're just doing finger sticks, you start doing them every 2 hours, depending on how the elevation of the glucose goes or how sick the child is. A CGM is a great modality to have at that point, so that you can really get a handle on what the glucose values are and the excursions that are being determined. It's important to look at how much is the child able to take as far as fluids. I would tell you at that point, nobody cares if they eat anything at all. It's all about fluids. So don't even worry about food. Worry about fluids and keeping the child hydrated. If vomiting occurs, I would say with COVID, you probably need to call a healthcare provider, or the symptoms of COVID at that point after even one episode of vomiting. And particularly if there's ketones involved. So you've got to get all that data, follow that data, be sure the glucose can come down and be maintained in a healthy range. You need to have glucagon on board in case you overshoot. You need to have, the ketone measurements, and you need to have access to a healthcare provider. And you really need to take this as a potential event that could lead to diabetic ketoacidosis. And, I don't know how many of you ever experienced diabetic ketoacidosis, either at the diagnosis or at some other time with your child. It is a very serious condition. It's potentially, life-threatening. And all that you can do to be sure that that doesn't occur as a result of the stress of the illness. Then obviously all the other things, you got to talk to your pediatrician, you got to get tested, you got to let the school know, you got to, isolate you and every family member that's come in contact with the child. Maybe I'll leave all those other things to Christa to talk about exactly how you do all that. But the big risk is diabetic ketoacidosis. I suppose in some of the younger ones, if they, felt sick enough and weren't eating and still had their insulin on board, it might be hypoglycemia as well. But this is straight sick day management. ADA has pieces on that on their website. JDRF does. I hope all of your healthcare providers have talked to you about sick day management, and you go into the mode of, I am now a healthcare provider parent, and you get all that data, you do all that prevention, and if you can't win, and it's often very difficult to win at home, you get pretty close to immediate assessment by a healthcare provider into a healthcare provider to help you. I do want to say one thing, we don't stop insulin. You know, everybody kind of has this presumption they're not eating, they're a little bit sick, maybe I'll hold the insulin. You do not stop insulin. You may have to alter the dosage, but the concept that I didn't give any insulin for a long period of time will not help the situation at all. Fluids are important, insulin is important, monitoring is important. Nobody cares about food.
Thank you. And Dr. Singleton, did you want to comment on distancing if there is a family member who's sick?
Yeah, it can be challenging, particularly in our multi-generational family homes, so that the individual, let's say that the person that's affected is not the child with T1 diabetes, but is the person that is most affected, who's a COVID positive case, will need to have their own room and their own accommodations, and regretfully, that people should stay as far away from them as possible. If they are, you have to interact with them, you're using some sort of cloth face covering. I noticed in the chats, moving past here, someone asked the question about what type of face covering is best. Right now, cloth face coverings, I don't have one right in front of me, but one that has two-sided fabric is ideal, will serve the purpose. A bandana, tightly used, will serve the purpose. Surgical masks and N95s are not needed, but the point is that in that setting, the person who is infected has their own space and the others are not involved around them. In this learning to how your community responds to this or is affected by this, is that you can find information at your state and local health department as to how much COVID is in your area. Your school districts will likely be making decisions as to how they move in and out of these virtual settings based on the amount of community spread of COVID in their communities. And so we look for how much is showing up in testing, how many people are positive from those testings, how full the hospitals are. And it's those types of data inputs that what hopefully will be informing school officials as to whether or not to go to school or not. Lastly, I noticed in the chats that someone asked a question about testing results. And testing is right now community by community dependent. And so CDC is in the process of updating its guidance as we now learn more about this, that COVID positive tests, or I should say COVID negative test, is not used as a return to school or return to work for a couple of reasons. One, it will depend upon the availability of testing in your area. Two is that we have found that sometimes people have resolved their symptoms, they have resolved the illness, they are no longer infectious, but they may continue to test positive several days on end. And so the way we are monitoring individuals that are infected is to wait for any symptoms, if they have them, to resolve, that there is a period of 10 days that moves from when they were first diagnosed. And then that's when decisions between the child, the family, and the healthcare provider are made in terms of them going back into physical school environments.
Thank you. And one other question to that point, but before I ask it, I just wanted to just do a quick kind of timekeeping. Right now we're at about 3:55, or about 5 minutes till the hour based on your time zone. We anticipated that we might run over, and so we're going to go ahead and just see if we can at least get our kind of a couple more questions in. and then wrap up. But I did want to let everybody know that this is being recorded. And so if you do need to leave at the top of the hour, you can, there will be other ways to access the information. So back to Dr. Singleton, my question or clarification is, are there regional or ways to figure out the COVID-19 in your community, or the incidence prevalence in your community to make a kind of a regional decision?
Well, again, as we say, all politics is local, all disease tends to be local. So the first place that we would recommend you look is at your state or local health department. And those health departments are keeping track of the positive case counts in that area. And as the virus spreads in the community and more people as the virus spreads, then the rate of people being positive and being truly infected is going to go up. And so that would be the first place to look. The second place to look is then again, the same at the state and local health department. On those websites, they are keeping track of how full the hospitals are in terms of hospital beds, hospital ICU beds. For children, the children's beds are not usually as noted on those sites, but the hospitalization access is there as well. So your state and local health department is your first line check to see where the community spread is occurring in your area. Also, it's probably a key place to look for in terms of COVID testing sites in case you or your family members need testing options as well.
Thank you. And to Crystal, what are some COVID-19 related accommodations that might be included in the 504?
Okay, first I'm going to say, just in case I forget some key accommodations, to be sure to check out ADA Safe at School pages, because we have a page devoted to COVID-19 resources for back to school. With that said, be sure that your child can participate in all school activities. We've actually received some inquiries or some reported problems about athletes who are being told that they can't play sports because of coronavirus risk and because they have type 1 diabetes. So I think it's critical to include a provision about full participation. As I mentioned before, make sure your child has additional sick days and can take those sick days, have those sick days without penalty, and also with the benefit of being able to make up missed assignments and missed tests. School staff should undergo coronavirus precaution training before the school year begins, and appropriate PPE should be in place. So you'll want to find out what the status is of that with your school, and I would write that into your child's 504 plan. Make sure there's a provision in the plan that the parent will be promptly notified when a student or staff member is diagnosed with coronavirus or flu or any kind of transmittable disease. The students with diabetes should not be penalized for any absences as a result of a staff member or student being diagnosed, but you'll want to make sure you're notified ASAP. Somebody had asked a question about the clinics, and I know it's read in CDC guidance that there's a recommendation to have a well clinic for routine care for medications for kids with diabetes, and then to have a sick clinic so that if there's any illness suspected, whether it be COVID or something else, that there be 2 separate clinics. Also, just accommodations following CDC's guidance, small in-person class size, mask and social distancing requirements in place, prohibitions against sharing objects like musical instruments and keyboards and other objects in the classroom. There should really be some restrictions in place there. Make sure that you write in that the school is going to have regular cleaning and disinfecting We want to make sure the schools are promoting hand washing and appropriate hygiene. We want to make sure the schools are minimizing the mixing of students in the buildings, you know, the hallways, the playgrounds, the cafeteria, and other common areas. Again, take a look at our coronavirus resource page. We're about to post some recommendations for college and post-secondary students as well, but that's a whole nother webinar. So.
Great. And again, links to a lot of these resources that we've talked about we will send out to everybody so they have access to them. Another question I had, this one is to both Joyce and Leah. We'll start with Joyce first. How should parents approach, so many schools, ideally every school has a school nurse right there in the facility, but that's not the reality. So what do you do if your school doesn't have a school nurse? You know, in terms of do you get other staff to be trained, or what recommendations do you have, Joyce?
Oh, that's probably the number one question that I think I've gotten over the years. And it's also a question that I've had over the years myself. But you're absolutely right. Budgets don't require schools to have a school nurse. But I, as a parent, have been taking care of my daughter Alexis' diabetes for 14 years now. And I'm not a nurse. So I'm a good example of, if you're willing to be trained and educated on diabetes, you can adequately provide care to our children with diabetes. I would also say that each parent should make sure they become familiar with their state and district's policies around trained staff and personnel, and also include that potentially in the 504 as well, because there are some laws and rules or policies around providing trained staff. So if there is no school nurse, most have a health clinic aide or someone that is responsible for that the children go to for general health there. So I think to approach it and understanding, and again, not demanding, because this sometimes is outside of the immediate school's control to actually have a school nurse, but to have trained staff. The approach that I found that works for me, and I know it has for other parents, is many times it's finding someone that's willing to be trained, someone that you built a relationship with that may be providing care for other students, or maybe just willing to take on the training, but as a parent be willing to provide the resources as well. And that may look like, again, a CDE, or the pump companies oftentimes will come on site and provide that training to the school personnel. Sometimes that lack of willingness on the school side, again, is the fear of the unknown and not understanding type 1 diabetes. So I think, again, approaching it gently and understanding where they're coming from. But when it comes to the school nurse, it really is a matter of, it doesn't have to be a school nurse to provide the care that's needed for our children. It needs to be someone that's willing to learn, be willing as a parent to provide the training, the resources to make sure that they're adequately trained. But first, be well versed on your state's laws and school district's policies as it relates to having trained staff, and make sure that there are backups in place as well. Because even if there is a school nurse, the school nurse may be busy with some other children, especially in what's going on now. But make sure that there's also a trained backup in place, and that that's documented as well, and that others know who that backup is in the event that the trained personnel is not available.
Thank you. And Leah, what would you add?
Well, I would reiterate what Joyce has said, that the states do have different laws regarding diabetes care in the schools. And many of the states allow delegation of diabetes care and or training if there is not a school nurse in every school. And that is key, is the training, and also following up after the training, supervising, getting back in and looking at the logs, making sure that the people that are trained are providing the care properly as they were trained. So that's a real key factor. But the school nurse, many school nurses are consultants and will assist and work with the parents in training staff, or they're responsible for training and delegation.
Thank you. This is a clarification. There are a number of people in the Q&A who wanted a little bit more information about what is considered good control in terms for kids with type 1 diabetes, or with both types of diabetes. So Dr. Kaufman, could you tell us a little bit about what guidelines say for this?
So there are a number of guidelines on this, both international and national guidelines, and the goal is to have an A1C 7.5% or less is considered the target. It doesn't mean if the A1C is 8.5 that, you know, in a young child that it's actually harmful at that point in time, but we start to get to the A1Cs of 13 and 14%. You know, the child is spending almost all of the time in hyperglycemia. And although we wouldn't call that child immune compromised, that high glucose value is affecting some of the tissues. So we really don't want to see that, and particularly if it's gone over a long time. The goal is less than 7.5. Depending on things, you know, certainly the adolescents end up on average around 9. So, and that's just the national data that we have. And I would just say, if your child's A1C is, 12, 13, 14, you really need to work on not only maybe the physical aspects of diabetes and what insulin dose and what devices, but maybe some of the psychological aspects as well, as to why things are so difficult for your child to manage their diabetes, and why it's so difficult, perhaps, working as a parent-child paradigm to achieve what you need to.
There we go. Thank you very much. So, we're at about 8 minutes after the hour. I think this is a good time to wrap it up, but I think this is by no means the end of the conversation. I want to thank our incredible panelists for taking time out of their very busy day today to provide this information to the community. I do want to remind everybody that this is a very individual decision, and the things we talked about today is by no means medical advice. Each person with diabetes has their own right answer for, right answer for right now of what they should do for school or diabetes care or things like that. So it really, today's talk was designed to inform, to educate, and empower, so that you can make that individual decision that's best for you. In terms of next steps, I did want to mention one of the things that, the more we can learn about how COVID-19 impacts people with diabetes, the better we can provide more information. One of the things we've created here at SDRI is an anonymous survey, and so we've included that link. The more people who respond, the better data that we have to be able to inform our understanding. So I encourage everybody to take that survey. If you are a parent of a child with type 1, you can respond on your child's behalf. I thank the panelists. I want to thank JDRF and ADA, and a special thank you to Katie Hawk of SDRI, who spearheaded this town hall and made it happen. We will be sending out the email with resources and links, as well as we'll put them on the screen as we close. And with that, I thank you all for taking time out of your day to learn a little bit more, and perhaps we can do this again in the future.
Yeah.
Thank you for having me.
Bye, everybody.
Bye-bye.
Best
Thank
of
you.
luck.
Stay active out there and stay informed.
Yes, stay active, yes.